Hello, everybody. Welcome back to the Incubator Podcast, live at Hot Topics in Neonatology in Washington, D.C. We have the privilege of having on today two legends of our field, Dr. Jeffrey Gould and Dr. David Stevenson. Thank you guys so much for making the time to come on the podcast.
Pleasure. Thank you.
For those of you who are not familiar with your work, and shame on them, Dr. Gould, you're the senior advisor and co-founder of the California Perinatal Quality Care Collaborative and the Robert Hess Endowed Professor of Pediatrics at Stanford University. You guide statewide quality initiative to improve outcomes for California's most vulnerable patients. Dr. Stevenson, you are the Harold Faber Professor of Pediatrics at Stanford University and Senior Associate Dean for Maternal and Child Health, where for decades you've shaped the field of neonatology, and you direct Stanford's Prematurity Research Center. We're very grateful for you guys to join us, and I would love to talk about the CPQC and understand a little bit the inception story of that collaborative. I think in the mid-1990s, I was reading California was really considered a very fragmented state. Can you tell us in this context how the collaborative came to be?
Well, David, how did this was your idea, and maybe talk about your notion about why we should really do a collaborative.
Well, I thought that I've worked mainly in just straightforward translational work in the nursery and had done work in mice, rats in the beginning, and then mice. And I felt that we were missing in our division expertise in perinatal epidemiology and health outcomes. And we needed to build our program in a way that would allow us to work at the level of public health. And I thought that a wonderful opportunity would be to take whatever we were discovering and ultimately bring it to quality improvement within the state of California. And to do that, we needed an organization that was going to position us for that kind of translational work at scale. I knew nothing about it, so I had to find someone who did. And I found him sitting in a hot tub in Carefree, Arizona at an American Academy meeting, and we talked, and the rest really is a part of that history, but it was really, really important to begin to work to change the behaviors of physicians and other healthcare professionals in an effort to improve care at scale. And that's what we really worked on establishing in the state of California.
Wow. Dr. Gould, how was the early steps of the collaborative? And I'm sure it's not an easy task.
No, it's really quite interesting is that I was really excited that David really, I had a grant with the California Maternal and Child Health. And what we were doing is risk-adjusted neonatal outcomes for all about 380 delivery sites in California. And when I took this on, I said, well, neonatal mortality is such a distant outcome. Will you give me some money to do some morbidity to see if we could really get an all-California morbidity database? And they said, sure, they do that. So I had this little tiny bit of money, but I had no opportunity. Then David came and said, hey, what about this idea of our all-California morbidity database and quality improvement? So I was very excited, and I had worked with Jeff Horbauer on Vaughan, and spoke to Jeff and said, well, what do you think of the idea of making California a whole Vaughan member, that we would try to do all of California?
It's the Vaughan franchise.
The Vaughan franchise. And so Jeff said, sure, between sailing trips, because he would come out and lecture at Berkeley, where I was a professor, and we'd go sailing. So we talked about this. So we had the go-ahead. The only problem was we had this environment that was impossible. Everybody laughed when we said we wanted to have a collaborative, a statewide collaborative. In part of it was because our stakeholders really weren't talking to each other, MCH and CCS.
Yeah, right. And I was naive in that regard. I thought that the state was the state, and it was sort of one big thing. It was basically silos of people with different responsibilities within the state.
Yeah.
And that was a fractionation of the resources that we needed to actually be assembled to carry this out. And one thing that Jeff asked me about in the very beginning is that we also then established the California Association of Neonatology.
Yeah,
neonatologists. And that that organization then was an avenue through which we could work to then put together this system. But it took a year or so before we could convince the leaders of these different silos in the state to actually cooperate, as well as people like the Pacific Business Group on Health and other partners that were going to be a part of this effort.
What is the motivation that doesn't let you give up in this process? Because it's long, and when I'm assuming that when you're hitting a few obstacles, you're wondering where if people are not in the same mindset as me, and I don't see the momentum carrying us through, maybe it's a bit discouraging. But you persevered.
So like quality improvement is really difficult,
Mm-hmm.
and you got to sign on forever. And if you're in quality improvement, our whole idea was that we knew what was going to happen overnight. It was going to be difficult, but we were just going to keep doing it and doing it and doing it because it was the right thing to do.
Right.
I mean, it was not like, it was not like we wanted to write an article. It was like we really wanted to see improvement in healthcare.
Right.
So I didn't know what to do because everybody was kind of arguing and stuff. But I had friends who were in organizational development, and I explained to them what was going on. And they'd say, "Well, what do you know about organizational development?" And I said, I don't know really anything about organizational. And they looked at me and they say, "But you're trying to create a complex organization. Didn't you learn this in public health school?" And I said, "No, in public health school, they said you just put everybody in a room and something magic was supposed to happen, which never did happen. So they kind of outlined for us the steps to go, meeting with each person, trying to figure out what is the value for the various stakeholders to participate. The idea being to move someone from a stakeholder to a partner, and to become a partner, it has to be valuable for you. So this is kind of what
Yeah,
you did.
you put yourself in their shoes,
Yeah.
so to say, and try to understand a little bit what
Well,
their incentives are.
And it's interesting that, we were the first in the country, so other folks came to us, the second round of folks. And what would they would come and they'd say, "Well, we need a beta database. How much is it going to cost? And should we?" And I said, "Wait a minute. You don't need a database. You need an organizational development person." So that's kind of like what we push. When we started CMQCC, the sister organization, I recruited Elliot Main and I said, "Elliot, would you be adverse to working with an organizational development person?" And he said, "Sure, I'll do that. Cost a lot of money because they're very expensive." But it was really incredible. I mean, it was like after about 3 meetings, we had to go around the table to say what was going on. And one of the people that we recruited because he was so important obstetrician in Southern California was a very difficult person. I mean, really difficult. And people said, "How could you have this guy in the tent?" We said, "Well, we actually needed him." And so it's going around and I'm just dying. Everybody say, "Oh, this is, and we get to him and I'm just like, and he said, "I've been on a lot of committees and I've done a lot of things. I've never done anything as valuable as participate."
Oh, look
in
at that.
this." And I said, "Wow, like paying all this money, this developmental, guy was really important because he helped us really put things together."
We had this issue in the state, which was that we had people who were based in the academic centers and people who were in private practice. And that was another blending that had to occur. And that's where probably I had some role because I was in various leadership positions within the academy. And I helped then create District 9 organization for the academy. And Joe Butterfield had done the same thing and was sort of a guide to that. He was in Colorado. But we combined that with these other efforts, and the whole thing gelled over time. We also had some additional funding support from the David Lucille Packard Foundation,
Right.
which also supported Vaughn. And those are the things that sort of, created the grain of sand that then became the pearl that now is functioning for the state. We have much more work to do because now we're trying to develop infrastructure, data systems, reporting systems, and so forth, the same kinds of things that Jeff is expert in for the community. most of the early work was focused on what was happening in hospitals. And I think as we move more into the obstetrical world, which is what's happening, I think necessarily because these two worlds are together now, we needed to to really get that kind of expertise built into the system. And that's where the state now has an interest, because once we do that, we have everything that relates to maternal and child health in the state of California. And that's a demonstration project for the country.
Yeah, I think that's been the theme. The CPQCC has been sort of a model for the rest of the country in how to operate and the work that you guys are doing. Looking back at this adventure and how it is continuing, what are some of the work that has been done through the collaborative that you're the most proud of?
I'll let Jeff describe. There's plenty of examples.
I'm sure.
Early ones were as impressive as anything, but there are even more recent ones, I think, that have been incredibly important. I think the one on maternal mortality is one of the biggest achievements that Elliot was involved with CMQCC.
Well, I think we've had a lot of, achievement. California has the lowest maternal mortality. The country keeps going up, and we keep kind of like trickling down. And this is because, of quality improvement. And when we do quality improvement, we really bring everybody into the thing. We've done quality improvement on maternal hemorrhage, where we've had 150 units, and we have a very, very disciplined kind of thing where these units are meeting in pods of 10 every 2 weeks, and really looking at their data and trying to refine what they're doing. So I think the kind of techniques that we're doing, are really important. Again, our orientation is value. When we do one of these quality improvement things, what's the value? What's the value for the patients, for the families, for the people that have to do it? So this is, to us, I think I'll tell you what I'm really,
Tell us what you really are proud of, Jeff.
what I'm really proud of is we put on a QI in a part of the state. And people said, you can't do it in that part of the state because the 3 or 4 highly intensive care units were really, really competitive. And they said, you'll never bring these people together. And so we brought them together, and they planned a quality improvement. And everyone said they'll never share their data. And after they started to do this quality improvement, when they were in it about 2 months, they said, we can't do this without seeing each other's data. And so quality improvement is kind of structural intervention to build relationships, to build camaraderie. It's an enterprise that results in positive stuff for others. Our pregnancies are better, our neonatal outcomes are better. But more than that, quality improvement also improves the working conditions.
Right.
That one of the things that we're pushing is that we want to build strong, non-hierarchical teams.
Right.
And that's one of the focuses that we look at when we put on a quality improvement thing. It's almost a structural intervention to build teamwork within these NICUs.
It's a culture, I think.
A culture change.
I like this word, structural intervention. We have a lot of young career physicians, trainees that listen to the podcast, and it's such a pleasure to have both of you on. For those of us who are listening and who are inspired by the work you've done and who are trying to maybe emulate this type of initiative in their own locale, what is the advice that you would give to each of you give to a young career physician who's trying to follow in your footsteps?
You find someone like Jeff Gould.
You're punting.
Yeah. No, I think it's important to devise a system that has not only clear metrics but also real-time data that can be used, and that especially for intensivists, that part of the puzzle, that's a really good thing because they get feedback immediately and they can make change, and they can see that. But I think that it's this notion of being able to work in teams and then be persistent and always look for what the value is for different partners. I mean, if you have to be able to translate into someone else's language why it's something they should be doing. And if you learn how to do that, then eventually it'll work if you've got persistence, which we do. But, it helps to find a guy like Jeff.
Yeah.
Well, yeah, I think if you're a young person and you're working in the NICU and you want to start to do quality improvement, you should sit down and find out what you want to do, and not what you want to do, but what folks want to do. And it's important for everybody to say, well, here's something that we want to improve. And so it's you want to start building teams right away, but the teams have to have a goal. And you have to figure out, well, what's in it for the team? What's in it? And it's worthwhile sitting down and saying, well, if we do this improvement, you know, what's actually going to be improved? It's not just the outcome. We had a small unit up in Oregon that I was working with, and it was a really tiny unit, and it had 3 or 4 local doctors running CPAP, and each doctor had a different way of taking you off CPAP. And the nurses were going crazy because depending upon which baby it was, they'd have to find out which doctor, they'd call that doctor. So they got together, the nurses, and with the physicians, they said, can we please figure out a single way to do so everybody's doing the same? And it turned out that when they did that, uh, everybody came together, and they really, that they never thought they'd be able to do it. But when they actually said, "Here's our goal, here's why we wanna do it," and it'll really make our lives as nurses better. It'll free up all this time, and it also freed up a lot of extra equipment because, you didn't have to keep them on CPAP as long, and they saved a lot of money, and they needed that money because it was a small little unit. So finding something that's of value and then working towards something that everybody agrees is, or most people agree is of value, is the way a young person should uh, move forward in the quality field. Not to come up with their own ideas, although they may have their own ideas to field, but really to sit down with your colleagues and say, like, what should we do? What should we do? Where do we? And the reason data is important is it points out areas where you're challenged, and the
In a
importance
very honest manner.
that that's right.
It's evidence.
Yeah, because everybody knows that what they're doing is absolutely fabulous. Like it's like how could I ever improve what I'm doing? It's fabulous, and so then you show them the data, and they say, "Oh, gee whiz, maybe." I wonder what those other guys are doing that I should be doing myself.
There's one more transformation that's taken place, Jeff, which is in the academic centers. It's now for promotions, people, they take quality improvement work seriously.
Yeah.
And there are better ways to evaluate the accomplishments of young people. And so there are academic pathways as well in the academic centers for people to be focused on quality improvement. And I think the other thing from my perspective is I didn't train in public health. And so working at scale is a different set of problems.
It is.
And I think that we can do a lot as we work with our individual patients, and we can do sort of traditional clinical trials and things of that sort. All that's important. But to move from that to really quality improvement and to the level of public health, those are things that require unique expertise that Jeff has had and others now can develop because the institutions are willing to support that kind of a career path.
Absolutely.
So,
Dr. Stevenson, Dr. Gould, thank you so much for dropping by and sharing the pearls of wisdom. We really appreciate it. And again, it goes without saying, congratulations. This is an impressive body of work. Thank you.
thank you.
Thank you.